This is Trail Guide Chapter 4, 6th edition of the Trail Guide, and it's regarding the spine and the thorax. As with each chapter, we'll start with the bones, the bony landmarks, and then move into the muscles. So the first page I want to just have a quick view of is page 168. And this is the page that I suggest that you come back to after you're done with this study lecture and make sure that you can visually identify all of these places, and that will help you tremendously on your chapter test, but also making sure that you have the right terminology for what is needed. Going to page 170 next. We're going to start with the information at the top, so I can make sure that you have all of it highlighted, which is all the information on the bottom. So this is talking about the vertebral column or your spine, and we're going from the cervical, the thoracic, and the lumbar area, but we will include the sacrum and the coccyx as well. Starting right off, we have our 7 cervical vertebrae, so going from C1, which is actually up in your skull, all the way down to C7. Then we have 12 thoracic vertebrae. These are all the ones that are going to be part of your rib cage. And then all the way down on the bottom, we have our 5 lumbar, and then we get to our sacrum and our coccyx. Here you can see that I have written out that the sacrum is 4 or 5 vertebrae that are now fused together, and then the coccyx is 3 or 4 vertebrae that are now fused together. So you do need to know the 7, the 12, and the 5. We have a total of 24 vertebrae. You do need to know that they are the terms cervical, thoracic, and lumbar. We are going to talk more about C1 and C2 on the next page. But you also need to be aware of the ribs. You need to know where the lumbar area is. But back up on the top, there is some other information that I want to make sure that you have highlighted. The cervical vertebrae are the most movable and the most accessible, with the exception of C1, which again, up in the skull. The 12 thoracic, or the rib cage vertebrae, those are the ones that are designed for minimal movement because they're trying to stabilize this area and protect the internal organs, the lungs, the heart, all the things that are inside our rib cage. When we get down to the bigger vertebrae on the bottom, the lumbar vertebrae, their job is to support the entire weight of our upper body. So these 5 have a lot to do, and we'll see how they compare in size and difference. Back at the top, there's some information here regarding the rib cage. There's another page here, page 173, which is a little easier to think about and look at. So I want to make sure that you have this information highlighted as far as for the term thorax and sternum. But again, those are pictured a little better on another page, and then the rib cage information as well. So you might be flipping from this information to the other page as we go through that, because that will make more sense as we get that different picture. On the top of page 171, just another overview of all of the different areas, but we're going to start our journey of talking about the difference between C1 and C2 and all of the information that you need to know about this. Starting with the terms. C1 is the atlas, C2 is the axis. You also need to know that all motion of the head comes from C1 and C2. As I mentioned, C1 is up in our skull. And so the only difference between C1 vertebrae and all of the other 23 is that there is no spinous process. So let's just look at a couple terms so we can define what these are. So first of all, I want you to look at C2 because this will help us with what we're looking at. spinous process is on page 176, and we need to see what that is in order for us to understand why C1 does not have one, but C2 does. So let's go to page 176. The spinous process is the most posterior projection of a vertebrae. So if you reach your hand around to the back, when you feel your cervical or down to your thoracic, that's what you're feeling, is the spinous process. So all of this in the picture here you can see. So you always will be able to access them except for C1, which does not have one. Down in our up in our cervical area, there is something that lays on top of the spinous process to help protect it. And it actually, there's another ligament that processes or extends all the way down. And we'll look at that at the end of the chapter when we see that. But I have written here flexion and extension in order to help feel your cervical spinal process. So if you just put your hands behind your neck and you bring your chin down and your chin up, you will feel your spinous process popping in and out a little more. So it just makes it a little easier. Before we go back to that first picture of the bones, I want to focus a little bit more on all of the spinous process of the cervical, page 179. Again, just seeing how they're projecting out, but I do like this view so you can understand that C1 is up in our skull, and they're showing here C3 through C6, but they actually have C2 through C7, and this is where we're talking about the extra padding that is on the spinous process, which is the ligamentum nuchae, which lays on top of this. We'll get to that when we talk about the other structures that are on top of the bones. The other area that I want to identify on all vertebrae is the transverse process. The transverse process are what are on the side of the vertebrae. So we've talked about the spinous process being the most prominent in the back. Now we're going to talk about what's on the side. So if I put my fingers on the side of my vertebrae, that's where my transverse process are located. So they're on the side of the vertebrae. It is where we're going to be attaching muscles throughout all of our transverse vertebrae, up and down our vertebrae. But also we don't want to forget that brachial plexus, which goes down our arm, is going to be coming through our transverse process area. So we're just defining transverse and spinous process. So now I want you to actually turn back to where we started, looking at the difference between C1 and C2 on page 171. So we know that C1 has no spinous process, but I want you to also notice what I have highlighted here. We have transverse process, which I just talked about, so you can see those. But I want you to compare the difference between C1 and C2 in the transverse process, just seeing the difference of what they look like. I also have, the vertebral foramen here, and I have it highlighted. Look at the difference in the whole of the bone, or the opening or the passage, between C1, which again up in our skull, and C2. Okay, so a lot of difference there. And then just seeing how the spinous process on C2 starts to extend out, that helps us remember that that is the difference between C1 and C2. C1 up in our skull, and it is the atlas, and then C2 is the axis. We'll look at how these two joints work in a little bit when we get to the back of the chapter. This is page 172, and this is where I want to introduce the term that I have written here on the bottom, intersegmental mobility. This is where each area of the spine has different movement. So we need to keep that in mind, especially as manual therapists. As an overview, I want you to just look at the spinous process of the cervical versus the spinous process of the thoracic. Notice the differences, right? If you go all the way down to the lumbar spinous process, there is a huge difference in what that one looks like. So that's just comparing spinous process to spinous process to spinous process. You can also see on the right-hand view how it changes in shape. Still protrudes out because it is that posterior projection, but it is definitely different in its shape. So then let's look at the transverse process, comparing the cervical transverse process, where the transverse process actually really projects out to the side on our thoracic, so on our rib cage area, and then all the way down on the bottom looking at that transverse process of the lumbar. There is a huge difference in those as well. When we go over to the right-hand side, transverse process, look at how little it is in the cervical vertebrae versus the transverse process of the thoracic. Again, this is where it really starts to change when you compare between our neck and our thorax. And then all the way down they change, and they're not as prominent in our lumbar transverse process. In between the spinous process and the transverse process, we have an area that I have here in blue. It is the lamina, and it's the lamina groove. So we have spinous process, lamina, transverse process. The same for the thoracic, spinous, lamina, and the transverse. We will palpate this in class and you'll be able to feel these differences. And then again, down on the bottom, look at that lamina groove for that lumbar vertebrae, extremely different. And then the last part that I have highlighted right in the center is the opening in the center of each of these vertebrae. Very important when it comes to the mobility of our spine. We have to keep in mind that all these are different. And every area of our spine, again, it has its own mobility that it is capable of. So just defining those separate areas of each vertebrae, that's very important to do because that's how the muscles are going to lay. If we turn the page to the top of 173, this is the information that was on page 170 that I said it's going to be a little easier to visualize it here. So we're looking at what happens within our thoracic area, so within our rib cage area. So on our anterior view, I want you to focus on this one. This is our sternum. You need to know where your jugular notch is, right here at the very top. Right below that is the manubrium, or the shield, like a flatter part. There is an angle or a joint right here, and then we get down to the body of the sternum. And at the very bottom here we have the xiphoid process. We're probably more familiar with that one, but you do need to know all of where these are. What happens on either side of that sternum is it's where the rib cage is going to connect, but we have costal cartilage that is helping to connect our ribs to our sternum. So it's a strong protective tissue capable of withstanding repeated stress, and it is flexible. But the difference between how the ribs are connecting has to do with whether or not it is a true rib or a false rib. So on page 185 is where they define these a little bit more. So between 170 and 185 and this page, get a better picture. But true ribs are numbers 1 through 7, and this is a pair. Each one is a pair, and they attach directly to the sternum. The false ribs attach indirectly to the sternum by this costal cartilage, which again, very, very flexible. And then the last two, numbers 11 and 12, do not attach to the sternum or the costal cartilage at all. So that's why they're considered the floating ribs. They do still have a job of protecting our internal organs, but they're floating to make that happen. So knowing the difference between not just the vertebrae, but also in the thoracic area and what the terms are that we need to be aware of. 174 is where we're going next, and I just want you to look at this and know that these bony landmarks are going to absolutely help you in identifying these places on a client. If you take into account that C7 is at the base of the neck, or you could say C7 is located where the shoulder meets the neck, we know it's most prominent there. T7, or thoracic 7, is located at the inferior angle of the scapula, going back to chapter 2. So you don't have to individually try to count each rib. You could say that it is at T7. The same with T12. That is all the way down to where the 12th rib, or that floating rib, is located. And then lumbar number 4, or L4, is going to be at the top of someone's posterior iliac crest. So knowing these will help you in being able to identify that if you need to document that you avoided an area on a client in your treatment because they had something there. They had a redness, they had a raised area, something to that effect. You would be able to document appropriately. What is on the bottom of 174 is extremely important information for those of you that are going on to take a state exam. I promise you they will ask you something about lordosis or kyphosis. The very bottom of the page, you can see we have the definitions of what they are. Might not be what you thought. So bent or curved or stooped is kyphosis. So we have kyphosis showing in the thoracic area and our sacral area, which means it is bent or curved or stooped, which is the opposite of lordosis, which we talk about in the cervical or the lumbar area. This is bent backwards. So you might think of kyphosis as a posterior bend, and lordosis as an anterior bend. For me, it's a little easier to think about that, and that might help. So you do need to know that kyphosis and lordosis is possible in any area of our vertebrae, but usually we think of thoracic kyphosis as being more hunchback and lumbar lordosis as being more sway back, but they can occur at the cervical and down in the sacrum. So know those two terms for sure, lordosis and kyphosis, and just be aware of what they look like. That's going to help you with your visual assessment, because usually you don't have that much time when you're working with a client to try to take in all of the things that they're talking about, so your visual clinical skills are going to be very important. The top of page 175 is something that we will do in class, but it is going to help your skill of knowing the difference between the spinous process, the lamina, and the transverse process, all the way from the cervical down to the lumbar area. You will be able to palpate all of these. So just being able to be very confident in what am I touching, because that's what's going to help you in the muscles. The bottom of 175 is specifically talking about what is going on with the lumbar vertebrae and how those lumbar vertebrae are supporting all of our upper body. We need to be aware of that, and we need to think of the spinous process and the transverse process within that. So you can pause the video, you can read that, get a little bit more understanding, or you can do that at the end. Either way, but please make sure you read through this information. That's going to help you in your assessment of clients, perhaps to creating a treatment plan that will be more successful because of what they do in their activities of daily living. Just want to remind you on page 176 of the areas that I have highlighted, and then how you can find a spinous process, especially in the cervical, but you can do the same in the lumbar area or the thoracic area. On page 177 It's that reminder that lumbar number 4 is going to be at the top of their iliac crest. We're going to talk more about the pelvic region and the iliac crest in chapter 6 of this book, but knowing that you can reach around and find your posterior iliac crest on yourself will help you be able to find that on your client, and that's where lumbar number 4 is. The same with where thoracic 12 is, down at the floating rib area. Sometimes you can feel these floating ribs on people. Sometimes you can't, just due to their body situation. On page 179, just to review, because we looked at that a few minutes ago, we're talking about what the spinous process are and how the ligamentum nuchae is sitting on top of that, and we're going to look at that here very shortly. So page 218 is one that you might want to come back and look at 179 for another understanding of what that connective tissue is. But I want to continue with just talking about the vertebrae before we get there. Page 180, again, transverse process, what is coming out the side of each vertebrae. And at the very top is where they're talking about compression or impingement of the brachial plexus and how that comes into play with our transverse process. Page 181, this is where we're defining the difference between the spinous process, the transverse process, and the lamina right in between. So the groove is a trough space. It goes all the way from the cervical down to the lumbar. So you will be able to palpate all of those areas. There is a layering of muscles that it is important for us to know the difference between where is the spinous process, where is the transverse process, and then where is that lamina groove. On the top of page 182, this is exactly what we're going to be doing in class. So this is a good visual. If you have the opportunity to practice this before we do it in class, that would be great. So it's just showing the difference between the transverse process and the spinous process, and then that area that is in between the lamina groove. And again, you can feel that on all the cervical, thoracic, and lumbar areas. Another good visual on the top of page 183, helping you define that lamina groove. So again, that long vertical trough is how they describe the lamina groove. Changes in depth as it goes down our vertebrae, but you will be able to palpate that area on most people's bodies. I mentioned some of these pages when we were looking at the overview of the ribs and the sternum. So this is page 184, where they're talking about specifics within the sternum. That the page had the view of the sternum a little easier. So again, you might want to turn between these definitions and then that view of the sternum on the other page. The same for the costal cartilage definition and the ribs, just remembering which ribs are the true ribs, which ones are the false ribs, which ones are the floating ribs, and having to do with that costal cartilage that is helping to attach the ribs to our sternum. We mentioned this way back in chapter 2, but I want us to remember the first rib location. So this is page 186. And when we talked about the clavicle, this was our first introduction to the first rib being deep to the clavicle. So the view on the top of 186 reminds us that the clavicle is on top of ribs 1 and 2. And we can get through this area in that posterior triangle, which again is towards the back of the side of the neck. And we're going to we talked about trapezius muscle in chapter 2. Sternocleidomastoid doesn't come up until chapter 5, but that's coming up here pretty soon. but just remembering clavicle and first and second rib so we know where these things are located before we even get to that part. From here, I want us to skip to the back of the chapter because this is where we're going to start to talk about the structures that are laying on top of the bones, which is important for before we talk about the muscles. So that's where we're going next. And page 218 is where I want to go. So look at the bottom here. Nuchae is nape of the neck. When we describe what ligamentum nuchae is, we have to remember our spinous process. So this is the stuff that's laying on top of it. If you reach back and palpate it, you will feel like a little clunking of it. You can also grasp your neck. So this is the connective tissue that they describe as being fin-like. But it runs on the sagittal plane, so going back to chapter 1, make sure you remember what the sagittal plane is. But it is covering those spinous process, which is going from up external occipital protuberance, which is that bump right in the center of the back of our skull, all the way down to C7. It is to help stabilize the head and the neck, but again, it's connective tissue. And there is going to be the trapezius muscle attaches to this, and the splenius capitis, which we haven't had in the book yet, but we will. So just remembering this ligamentum nuchae is covering those spinous process, important not only for stability, but also for the attachment of the muscles that are going into our cervical vertebrae. That bottom picture again, just how you would be palpating it. If you had the client in a supine position, you can feel it or access it in prone or supine, as those pictures show. The top of page 219, on the left side, we have the supraspinous ligament. So this is what is taking over when the ligamentum nuchae ends. So you can see here down on the bottom, still covering the spinous process, but after our cervical area, we have to have something to protect those spinous process. So that is this ligament goes from all the way through the thoracic and down to the lumbar area. So again, just covering the spinous process for the same type of reasons as ligamentum nuchae. The right-hand side is showing a picture of our abdominal aorta, which we haven't talked about the diaphragm muscle yet. Page 213 is where we're going to talk about the diaphragm, but we need to know that the abdominal aorta is going in the front of our vertebrae. So it's about 1 inch in diameter. It is the chief artery for carrying the blood down to our abdomen and our lower appendages. It lies on the anterior surface of the vertebrae. So this is where if I could stick my fingers all the way through into the skeleton like I am on him, then I would be touching the abdominal aorta in order for all of my legs to have their blood flow. So this is why some people have limited or more lacking of blood flow down into their legs when this abdominal aorta might have issues with the vertebrae. So it's very internal. We're not going to get to it, but we need to know that it's there. When we do diaphragm release in our class time, then we will be feeling the pulsing of this abdominal aorta. We're not going to be affecting it, but you do need to know that it's there. And again, we'll look at this picture when we talk about the diaphragm as a muscle itself. Page 220 for the next lovely thing. This is one of my favorite terms about all of our body. It's the thoracolumbar fascia, or it used to be called the thoracolumbar aponeurosa, but it's actually more fascia than tendon, although they're both connective tissues. So in the previous book, they had it as an aponeurosa, but technically it is fascia. Back into chapter 1 if you need to review what fascia connective tissue is. So this is a broad flat tendon, diamond shaped as you can see, and it's the anchor for several muscles. So it lies superficially from the posterior thorax across the sacrum down to the posterior iliac crest and then up into the thoracic area. So that creates our diamond. But what I want you to notice is the muscles that are attaching to it. So an anchor for muscles in the thorax and the hips, including latissimus dorsi, which we had in chapter 2, and then the erector spinae group, which is one of the groups of this chapter. That bottom picture is a little bit better, showing where this diamond is located. And again, latissimus dorsi, we have our gluteal muscles. Right below the glutes, we have our hamstrings. We haven't talked about that yet. In this chapter, we're going to have we will have the 2 oblique muscles, so those are located here as well. So this fascia connective tissue, you're not going to be able to feel the difference between this white area, which is the fascia, and the muscles themselves, but you need to go back and review and remember that fascia, 1 square inch of fascia, of any of this fascia, can hold 2,000 pounds of pressure. So perhaps when you've had that client that said that, oh, I bent over to tie my shoes and my back locked up and I couldn't move, that was 1 square inch at least that found its maximum capacity, and it wasn't going to let go in that square inch until something in one of these muscles has changed. Rest sometimes can do that, but also there might be medications involved, so we need to be aware of those. We're going to look at page 221, 222, and 223. This is your visual observation with one exception. On page 221, this is where they have the atlanto-occipital and the atlanto-axial joints. So this is where we're talking about C1 and C2 and where they come into our skull and our neck area. So that's what we're defining here. No, you don't have to memorize this. I just want you to look at all those different ligaments. And here's the exception. When we have a client that has Down syndrome, this is something that they're born with. It's that chromosomal issue that they were born with, or how they didn't divide as everybody else's. There is an instability in 20% of people with Down syndrome in the atlanto-axial joint. So it's known as AAI. And what we have to remember as manual therapists is that this could occur in someone, that instability. So if we were to place our fingers on the back of their skull in the area of C2, we want to remember that there potentially could be an instability there. So I would caution you highly on placing your fingers when they're in that supine position, or the prone position, that we want to be aware that we don't want to create more instability in any of that joint. So there is one exception of what I want you to just remember about that atlanto-axial joint, and that's just where C1 and C2 are located, and we do put our fingers there and do a little bit of a hold. So that's why I want you to just write that down, be aware. In the other class, when we talk about some of the pathologies, we'll talk specifically about some other things to be aware of with Down syndrome, so you don't need to worry about that now, but you do need to remember that when you have a client, that yes, you can absolutely do all different types of treatments on them, but that instability could occur. So now we're going to move forward into the muscles, and there is several groups, but it actually is a little easier when we look at them as groups, as long as you remember the bones and the bony landmarks. So we're going to start on page 196, and this is our erector spinae group. So I have a couple things written here. ESG, that's how you might write that in your documentation. But I also have that lateral to medial, it's the I love spaghetti group. So this is to help you remember which one is the most lateral and which one is the most medial. And I have them defined out here on the side with the colors coordinating to what I have highlighted. So first of all, this group goes from our skull all the way down to our sacrum. So it is, in this picture over here on the bottom of the page, they show a tall pine tree. So these are considered some of our posture muscles, right? Because they're helping to hold stability there. They, as a group, again, top to bottom, but let's define the smallest of this, which is the most medial. So spinalis is the most medial. It's on our spine or our vertebrae. So it is the closest to the spine, and it lays in the lamina groove, which is the same for this entire grouping. Then we have longissimus, which would be your love, right? So we had spaghetti, now we have love. So this one is in the middle of our lateral to medial sandwich. And it also extends all the way down, top to bottom. The last one, or the most lateral, is the iliocostalis. So it's the one that is all the way out on our rib cage. Okay, so it is the one that goes beneath the scapula as well. And down here on the bottom, I have that in the lumbar region, so that lower area, this group lies deep to the thoracolumbar fascia, which we just looked at, that diamond shape that's down in the bottom of our lumbar area. But in the thoracic and cervical regions, we have to remember that we have trapezius, rhomboids, serratus posterior. We've already talked about the rhomboids and trapezius, but serratus posterior, inferior, and superior will be in this chapter. So this is just an overview. I do want you to note down here that the upper fibers of longissimus and iliocostalis assist in extension, lateral flexion, and rotation of the head and the neck to the same side. When we talk about the actions at the end, this might be something that helps you when we're looking at those as a group. So a couple things I want you to highlight, and remember we do the actions at the end because that is what I believe is the easiest. But as a group, these have an all-fire action. We are going to just look briefly at breaking them down individually. But as an entire group, one side or unilaterally is going to do that lateral flexion. So lateral flexion is when we're just bending to the side, okay? Bilateral, they are going to extend the vertebral column. Extension is standing up straighter and putting all of our vertebrae in proper alignment. It is not a bending forward or back, it's straight up. And when you look at this origin and insertion, this is for the entire group. This is easier and what I want you to be aware of instead of the individual ones. But individually, here is spinalis. And although this picture looks like it just shows one on the left side and a group on the right side, it is on both sides. But you don't need to individually memorize these origin and insertions. And the same goes with what is on page 198. When we look at the top, we can see we have the difference between longissimus being the longest. This is the one that is going to the mastoid process. And then iliocostalis, which this is the one that is deep to the scapula. Again, remembering that all of these go all the way down and include our sacrum. So again, you don't need to individually memorize origin and insertion here, but you do need to be aware of how they lay lateral to medial or medial to lateral. I don't care. Remembering that I love spaghetti might help you. I want you to write this for later sometime in later on in your career, that lateral flexion of the side, of the spine to the same side would shorten longissimus. I tell you that because sometimes we will have clients that talk about, I have one leg that is longer than the other, which has to do with how this erector spinae group is being attached and held down in our pelvis. So they're kind of walking in those situations in a consistent lateral flexion, and so that longissimus muscle is being shortened and weakened because it's being shoved more together. There is people that are born with one femur or fibula or tibia being shorter, but not as common and actually more rare than how we have held our posture to make that happen. On the top of 199, I just want to point out this little picture here that if you, and we'll do this in class during our hands-on time, but this is one way that you can get the erector spinae group to kind of pop up so you can feel it in that lamina groove and feel the difference. So you can have someone in that prone position, you can have them lift up their legs. You could do this as a passive action as well. You could lift up their legs, but I want you to also consider if you have a bolster underneath their ankles and they're in the prone position, what is that going to be doing to these erector spinae muscles that you potentially are trying to work with? Just as a thought process. We'll talk more about bolstering in class time. Let's move on to page 200. So as you can see, I have lots of stuff written for this group, our transversospinalis group. So I have there the TSG. So we had the ESG, erector spinae group. Now we have the next three muscles, transversospinalis group. I have them numbered for deep to superficial. So that's what the 1, 2, and 3 are. And as a whole, they connect from the transverse process to the spinous process. This group is also known as the stitching. And you can see in this picture why they're called that. So these are deep to the erector spinae group, so those first three muscles that we had. The three, multifidi, rotator, and semispinalis, are extending the length of the vertebral column. So again, going from top to bottom, so more muscles to help us stand up and be erect. But they have short diagonal fibers, which is where the stitching or the stitch-like comes from. So the erector spinae are help us to stand more upright. This is our stitching group, which is going to help with rotation, but also help our transverse process and spinous process do some action. So that's what we need to be aware of. So we'll start with the multifidi, directly accessible in the lumbar spine, so you're going to feel them very easily there. That's what that means. They're the only muscles that lie on the posterior surface of the sacrum. And although we are going to talk about the sacrum in chapter 6, I do want you to be aware that there is a muscle group that is laying in this area down on the sacrum. So you want to be comfortable with palpating the sacrum so you can reach back and feel that area right now. You could feel your multifidi on your sacrum. Then we have the rotators, which are a little different than our multifidi. They're shorter and smaller, and they're underneath or deep to them. Okay. On the bottom of the page, you can also see a little difference there. Multifidi on the left are a little deeper, but the rotators are the deepest. Semispinalis capitis is the other one, but I have to turn the page for us to be able to see what that one looks like. So this is at the bottom here. Okay, so you can look at that, or you can turn back to the paragraph to make sure that you have this information highlighted. So it's on the thoracic and cervical vertebrae, going all the way up to our skull. the semispinalis muscles are what they call the speed bumps that are on the back of the neck. So just so we can know where they are, so this is what we're talking about. See how they're reaching down into the rib cage area, so going down to the transverse process of the cervical and thoracic area, and then up to the skull. So in order to feel these speed bumps, if you put your hand on the back of your neck and then push your hand forward as you're pushing your skull back, you'll be able to feel what they're calling the speed bumps. So I want to go back to the bottom of page 200 because we need to look at the breakdown of the multifidi and the rotators. As a whole, I don't need you to memorize the exact origin and insertion of these muscles, but I do need you to know some information about them, which is actually a little better viewed on the top of page 201. So this is our origin and insertion. So just looking how, for the multifidi, their grouping or how they're reaching is bigger, or it's a longer span in compared to the rotators. Okay, so a shorter span. These are our shorter, smaller muscles. These are your bigger ones. They lay one right on top of the other, okay? But the rotator does not go all the way down to the sacrum. The multifidi does. So that is a difference between the multifidi and the rotators, because remember, the multifidi were the ones that you could feel on top of your sacrum, but those rotators you're not going to be able to feel. So the picture that is on the bottom of 200, again, just showing the difference, but then you'll notice here's the multifidi on top of the sacrum. I want you to write this down. We're going to talk about the rectus abdominis muscle later on in this chapter. So rectus abdominis is an antagonist during extension of the vertebral column, because these muscles, multifidi and rotator, are trying to extend our vertebral column. So down here in our lumbar area, there's going to be a fight between the multifidi and the rotators and rectus abdominis, so on the front of our body. So we'll talk about that more when we talk about those muscles. As a breakdown of semispinalis capitis, you can see that I have it broken up here for partial spinal head, because that's what semispinalis capitis means. But remembering that this one is the most superficial of the transversospinalis group, and it only goes to the thoracic and the cervical area, versus multifidi, which is going all the way down to the sacrum, and then the less or the deeper one that is not going all the way down to the sacrum, this is just to the thoracic and the cervical vertebrae. So that is our transversospinalis group as a whole. But I do want you to turn to the top of page 202. This is where we're showing the multifidi going all the way down to the sacrum. You will be able to palpate, but notice we have the spinous process in the center, and so the lamina, and then we have our transverse process. So that's why the bony landmarks are always extremely important that we talk about in the beginning. The bottom picture on 202 is just showing different ways we'll do these in class, so you'll be comfortable with what you are feeling within this transversospinalis group. On to page 203 to look at splenius capitis and splenius cervicus. So at the top here, I have that they originate on the spinous process and go to the transverse process. That might help you. So you can see in the origin and insertion area here. So they're going from the center out to the side. So to break them down, these are on the posterior neck and the upper back. So cervicus stands for the cervical area. Capitis is talking about the head. So if you can remember to break those down, it'll tell you where they are. But these fibers run oblique. So when you look at the architecture of them, you can see how they run a little differently. Splenius capitis is deep to the trapezius and the rhomboids, but also the angle that it has to go from that area up to the mastoid process, which is on the right behind our ear. We'll get to that in chapter 5. But that this is where that muscle is going. So it's deep. It has two other muscles laying on top of it. Splenius cervicus is deep to capitis, and it is going to be more in the lamina groove of this upper thoracic area and cervical area. We'll get to the actions at the end, but you can see how they're going from all the way down here. So we go all the way down and include to thoracic 6 as origin, and then they're going all the way up to the skull. So you can see if you compare the two origins all the way up to the insertion, it's really this upper back area, right? So what we can reach back and touch all the way up to our skull. That is why some of these actions are the common ones that people might talk about, that they have discomfort when they rotate their head one way or the other. I want to look at the lovely sandwiching, the submarine sandwiching that we have on our neck. So just how every muscle is working together to help hold that stability in our neck and our skull. So we've talked about trapezius. Then we have our splenius capitis, we have levator scapula, we've already had that, and then we have the sternocleidomastoid, which is not coming up until the next chapter, but we can see now we're getting a little bit more understanding of what's happening, and that is because of how that splenius capitis lays from that thoracic cervical area up to our skull. They are also indicating here posterior scalene. That's coming up in chapter 5 as well. Splenius capitis and splenius cervicus. I know that is actually, so we've had 3 groupings of muscles, erector spinae, transversio spinalis, and then we just got done with capitis and cervicus. So technically, we've had 3 plus 3 plus 2 muscles. So the good news with this next grouping is you don't have to memorize everything. So this is going to be page 205. And up at the top, I have some information highlighted, but I also have written that these are the suboccipitals, so it means they're below the skull. You need to know where they're located, right? That's easy. They're below the skull base. There are 8 muscles, 4 on the right, 4 on the left. You need to know that. And these are the deepest muscles in our posterior neck. You do need to know that. Their job is stabilizing the atlas and axis with all of the movements that we make in our atlas and axis. As far as the actions, I'm going to tell you why you don't need to know what they are. Because rectus means straight, oblique means diagonal, capitis means your head, posterior is the back. We have a major and a minor, so we know one is going to be bigger, one's going to be smaller. We have oblique capitis superior, oblique capitis inferior. So the reason why you don't need to memorize these is you need to know that there's 8 of them, that they're the deepest in the posterior cervical area. We need to know that they are stabilizing the atlas and the axis. And then you just need to be able to say, oh, they're rectus capitis posterior major, rectus capitis posterior minor. One's bigger, one's smaller. They're more straight versus the diagonal fibers of oblique. So you just need to know that there is 8 suboccipitals, and again, where they're located and their job as a whole. You do not need to know the breakdown. I do want you to circle rectus capitis posterior minor, because we're going to talk about that separately and having to do with the dura mater of our brain. So if we turn the page, I want you to go down to the bottom of 206. Down here on the very bottom, we have the definition of dura mater, which means tough mother, but I have written there, it's the outermost membrane of the brain and the spinal cord is the dura mater. And in this box that I have highlighted, specifically that rectus capitis posterior minor is attaching not only to the occiput, which is the back of our skull, so you can see them here a little easier, but also it attaches to that dura mater. So because of the advances in science, now we know that this muscle could be the one that is causing headaches or disrupting the flow of our cerebrospinal fluid when that particular muscle has perhaps some tension or the fascia is extra tight in it. So just knowing where these are is important. But you can't just dig in there, because you could cause a headache as well as help someone with their headaches, because this is more than just a muscle. It is attached to this outer membrane and the spinal cord. So it's always slower, and then even slower, so that you can make sure of what you are palpating and how you potentially are helping that client. So those are all ones talking about the vertebrae, the lamina groove, the transverse process, the spinous process. They're attaching to our skull, things like that. Now we're going to switch gears, but still talking about the vertebrae, because now we're going to go into the lower abdomen area. If there is a favorite muscle in the body, it's definitely this one for me, because of how important it is. So quadratus laborum, quad meaning four, so we can think of it as it kind of being a rectangle shape. It is the deepest muscle of the low back, or this lumbar area, but it is attaching to the floating ribs and down to the back of our pelvis. This is the deepest muscle of our abdomen, even though it's on the posterior side. So the deepest abdominal muscle. Okay? When we look at, again, where it starts and ends, I mean, if you want to exactly memorize origin and insertion, you just need to know that it originates on the pelvic girdle, or the posterior iliac crest, and it goes up to and includes the lumbar vertebrae and to the ribs. So you can see how it's attaching to those lumbar vertebrae. So this one is extremely important for how we hold our pelvis, because of just how the muscle lays. In this picture, you can see they have the erector spinae group laying on top of it, going all the way down that multifidi, going all the way down to the sacrum. I do want you to write this here. It lengthens the fibers on the opposite side, because that's going to be important when we talk about the actions. But for this muscle, I want you to look forward to, in class time, we're going to find this muscle in comparison to our pelvic tilt, because this will be important. So the best way to find this muscle is to walk with a neutral pelvis, so not in anterior tilt, not in posterior tilt, and being neutral. At the bottom here, we have just our black and white origin and insertion. So it originates posterior iliac crest, attaches to the transverse process of the lumbar vertebrae and that floating rib. So you can see it here. But also, the very bottom here, it's also known as our hip hiker, because its job is to laterally tilt or elevate the pelvis. But when we do that, one side is going to get shorter, the other side is going to get longer. But this will make more sense when we add on all of the other information as far as the actions. So on the top of page 208, this is where I want you to do this action so that you can feel your lateral edge of quadratus engage, or where you can feel it. So it might be hard to find your bottom rib, but you definitely can find your posterior iliac crest. And I want you to do the hip hiker thing. I want you to, wherever you're finding your posterior iliac crest, then I want you to elevate that pelvis, and right above that is where you can feel that lateral edge. It might be easier for you to do this on someone else when they're laying in the prone position or in a sideline position, but I want you to do this on yourself, and we will do it in class time because this can be a very sensitive area. So knowing what it feels like on yourself is definitely going to help that. So that's our deepest abdominal muscle, quadratus laborum. Next, we're actually going to go to the bottom of 209 before we focus on the paragraphs on top. These are the other 4 abdominal muscles. They are on the anterior side. Quadratus laborum is on the posterior side. So I want you to write this down, deep to superficial. Quadratus laborum we've talked about. This is transverse abdominis, is TA. It's on the next page or up at the top. You don't have to write it out, just write out the TA. The 3rd deepest is the internal oblique. 4th is external oblique. And then rectus abdominis being the most superficial. They do have that one pictured here. We can think of that as our 6-pack. But this right here, what I'll call the bandages, the skeleton bandages, very, very important. If you can just memorize this, you'll have all of the abdominal muscles down pat, because this is showing you the direction of the fibers. So that I strongly recommend. But also you do absolutely need to know this information, not only for your chapter test, but also for the state. All of our abdominals attach to the ribs and the pelvis. That's an easy way to think of origin and insertion. But here is what I have highlighted at the top, so I can make sure that you can go through that. So this is the muscular girdle that attaches around the sides of our thoracic area to the back posterior thoracolumbar fascia, and then it goes up and includes our rib cage, and then all the way down into our inguinal area, the very center of our pelvis. They are stabilizing the entire abdominal region, because that really is from our rib cage all the way down to our pelvis. They have them broken down here. So the most superficial being rectus abdominis, so that's our 6-pack. But the interesting part is it has 1, 2, 3, 4, 5. It doesn't actually have 6, but still, there's what it looks like. And rectus abdominis is lateral to the external oblique. So when you look at that bottom picture, you can see the external oblique going from the rib cage down to the center, but then rectus abdominis on top of it. Back up to the top, we have the internal obliques. These fibers are opposite or perpendicular to the external. So external on the top, internal on the bottom. So you can see now we've created the X and that star right in the center. And then the very last one, transverse abdominis. Okay, so our yellow here, the deepest muscle of this 4 group, because it is there to compress or helped with our forced exhalation. So we talk about this as being our girdle because of how it is placed. Notice it's more towards the bottom of our rib cage and then across our pelvic area. So transverse abdominis being the deepest of this group, but then don't forget quadratus laborum being that deepest one. So we're going to break these down from superficial back down to deep. The top of 210, most superficial, again, rectus abdominis. Rectus means straight. There is going to be an all-fire action of all of these muscles, and we'll get to that at the very end when we break that down. But I do want you to write that when we do flexion of the vertebral column, so a sit-up, we can say, it shortens the fibers. I do want you to write that down. That will be important when we talk in class about how to help with the diaphragm, or when people have restricted movement within their core because of this well-defined rectus abdominis. Then we have our external oblique. So external is the outside, oblique means diagonal fibers. It's also at the very bottom of your page there. So just looking at how it's attaching to, originating at the rib cage, going down to our pelvic area, and how it lays. Okay, so it is diagonal, but it's going to help. So I want you to write that this is rotating away for opposite side, and again, we'll talk about that at the very end with actions. So just know where external oblique is located. At the top of page 211, we have the opposite, internal oblique. So inside, diagonal fibers. Again, you can see how it's originating on the pelvis, going up and including the vertebrae as well as our rib cage. I do want you to write this down, that when we rotate to the right, it would engage the right internal oblique, and it's lengthening those fibers. So again, we'll talk more about the actions, but just write this down. This will help you in your future. And then the deepest of this four group is transverse abdominis. I have written here, it's the protective girdle. So when you look at the breakdown of origin and insertion, you can see how it's attached to the rib cage, down to our pelvis, but then also it's including our vertebrae, which is why it can compress our abdominal contents. Transverse means it has horizontal fibers, so that gives us like the girdle effect. So back to the very beginning of the abdominals. Now you can make sure, deep to superficial, make sure you know this as well as this. Moving forward, we're going to turn into the next muscle, which is our diaphragm. So we're going to talk about the information at the top. We'll go to the information at the bottom to go back up to the top. Okay. So the first thing that I have highlighted there, make sure you know for the rest of your testing career, if not forever, that the diaphragm is the primary muscle of respiration. That does not mean the primary organ of breathing. It's the primary muscle of respiration. Next we have that it has an umbrella-like shape to it. So you can think of it as an umbrella, all right? We know what an umbrella looks like when it opens up, so you can picture that, and that will make a huge difference when we talk about what happens when it moves or does its actions. The diaphragm's muscle fibers attach to the inner surface of the rib cage. So on Mr. Skeleton, it's easy to be able to stick your fingers up inside his rib cage. So our diaphragm is up in there because it has to do something to help with our respiration. At the very top of this umbrella, we have this central tendon, so that white area, that's going to mean something to us in just a minute, but let's get through all of this part first. The diaphragm creates inhalation or inspiration when its muscle fibers contract and